Well, it's 12 noon on the dot, Arizona time or Mountain Standard Time. Should we get started or wait another minute?
We can wait one more minute and then you start.
Okay. All right. Well, it is 12:01. I don't see anybody in the waiting room, so I think we'll go ahead and get started. My name is Jill Bullock. I am the Flex Coordinator for the Arizona Rural Hospital Flexibility Program. And we've been doing this multi-state learning collaborative for several years. But this year, since we have a fairly new MBQIP measure, which is the Medicare Beneficiary Quality Improvement Project on safe use of opioids, we've been doing this webinar series and hoping that all of the states that are participating do participate in this multi-learning collaborative. So today's topic is the dangers of co-prescribing, risks of combining opioids, benzodiazepines, and muscle relaxants. And we have a guest speaker today, Dr. Christopher Edwards. He's a PharmD at the University of Arizona. And this is brought to you by the Arizona Center for Rural Health, as well as the Arizona Comprehensive Pain and Addiction Center. Next slide. So just a few housekeeping items. You guys are all very familiar with Zoom. We will get the slides and the link sent out in a couple of days. And you are all muted. So if you could please enter any questions that you have in the chat box. And we will share all the resources in the chat. So feel free to share with your team and communities. And at the end, we will have a post presentation survey that we hope that you will all just take 2 minutes to do the survey. So I will go on mute and let Rocio take it from there.
Thank you, Jill. Hello, everyone. My name is Rocio Torres, and I am part of the Arizona Center for Rural Health with the Overdose Data to Action States program. And before we proceed with our webinar, I want to share our land acknowledgement. The University of Arizona respectfully acknowledges that it's on the land and territories of Indigenous peoples. Here we have an explanation on why we do a land acknowledgement. We invite everyone to explore this slide and the hyperlinks when you get the slides in a couple of days. The Arizona Center for Rural Health mission is to improve the health and wellness of Arizona's rural and underserved populations. We work closely with the Comprehensive Center for Pain and Addiction. Our experts focus on transforming healthcare for pain and addiction. Together with the students, educators, and community leaders, we empower those of us affected by pain and addiction to thrive. The Center for Rural Health and Dr. Edwards have no financial disclosures to report. We would like to pause and recognize the impact of this issue, the importance of this topic, and the work that you do in your community. Prevention, harm reduction, treatment, and recovery works. Starting in September of last year, 2024, two programs at the University of Arizona Center for Rural Health started working together to develop a multi-state learning collaboration. The goal is to support critical access hospitals with collecting the safe use of opioids measure by providing opportunities for exchanging knowledge and learning, and also understanding the public health relevance and importance. In November of 2024, we deliver information on the 2022 CDC Clinical Practice Guideline for prescribing opioids for pain. This year, we delivered treating pain in rural healthcare in February. In May, we deliver measuring safe use of opioids concurrent prescribing in collaboration with the Arquita team, Rural Quality Improvement Technical Assistance Research Center. And today, we are presenting co-prescribing opioids and benzodiazepines. At the end, participants will be able to assess the benefits and harms with co-prescribing medications such as opioids and benzodiazepines and become familiar with tools to help reduce risk. Our speaker today, Dr. Christopher Edwards, is an associate professor with the University of Arizona College of Pharmacy, Department of Pharmacy Practice, and Director of Emergency Clinical Pharmacotherapy with the University of Arizona College of Medicine, Department of Emergency Medicine. He maintains a clinical practice in the emergency department of Banner University Medical Center, Tucson, and has been an emergency medicine pharmacy specialist for over 15 years. Dr. Edwards has authored dozens of peer-reviewed papers and book chapters and serves as co-editor of a textbook titled Basic Skills in Interpreting Laboratory Values and as lead editor for an upcoming textbook titled Foundations of Emergency Medicine Pharmacotherapy. He serves as Deputy Editor-in-Chief for the Journal of Acute Care Pharmacotherapy. He has earned several awards for didactic and bedside teaching and leadership. Dr. Edwards served as the chair of the Board of Pharmacy Specialist BPS Council on Emergency Medicine. He currently serves as a member of BPS Council on Pain Management and as technical editor for the American Board of Emergency Medicine's Key Advances Certification Maintenance Program for all board-certified emergency medicine physicians. Dr. Edwards has served in other boards and committees, such as the American Society of Health Systems, Chair of Research for Arizona Health Professionals for Climate Action, Society of Emergency Medicine Pharmacists, Council on Education and Workforce Development, and American Society of Health Systems Pharmacy. Welcome, Dr. Edwards, and the floor is all yours. I will stop sharing now.
Okay, thank you for that kind introduction. I'm going to try to share my slides here. And hopefully that worked. Can you see my slides? You can?
Yes.
Okay.
No, we see your desktop. We
Oh.
see your
Yes.
beautiful forest.
Thank you. It is a beautiful forest. Let's see if we can get it to share the actual thing here. Share slide. How about now?
Yes.
Yes.
Okay, very good. So thank you again, Rocio, for the wonderful introduction. And, thank you for allowing me to participate in this event. Today, I'm going to talk about sort of the dangers of co-prescribing, different things that, fortunately, this combination isn't super common, but as you'll see, when things like opioids get prescribed with benzodiazepines and certain muscle relaxers, it can be a really dangerous combination. Typically, this combination is referred to as the Holy Trinity. And this was kind of my first exposure to this concept of co-prescribing. I was years and years and years ago, I was looking at forums posting information, sort of by recreational drug users for recreational drug users. And they would talk about this Holy Trinity. And I was really curious, okay, what does that mean? And basically that terminology refers to the combination of an opioid, and typically in this context, it was referring to oxycodone when combined with a benzodiazepine. And again, in this context, that was typically alprazolam or Xanax. And then mixing that with a third agent, again, a muscle relaxant, typically, again, in this context, carisoprodol, or more commonly known as Soma. And so that combination, again, is referred to as the Holy Trinity among people who are really seeking the euphoric effects from combining all those agents together. But for those of us who work in harm reduction and SUD and emergency medicine and toxicology, we tend to refer to it more as the unholy trinity. One of my colleagues here at the College of Pharmacy teaches the pharmacy students about avoiding this unholy trilogy of benzodiazepines, opioids, and skeletal muscle relaxants. So why is it so bad? Why would we call this the unholy trinity here? So when you combine these agents, opioids, benzos, and then, really anything that causes that euphoria and sedation, you're going to get additive effects, both in terms of the euphoria that's experienced, but also you see synergistic CNS depression. So the patients will get more and more drowsy. You'll see synergistic respiratory depression, and it dramatically increases the risk of having an overdose, and particularly a lethal overdose secondary to that respiratory depression. You'll also hear this combination, or these combinations, referred to as the double threat, which refers to an opioid or a benzodiazepine, or a triple threat, which is that holy or unholy trinity that we talked about earlier. Those are the terms that are more common when we look at the literature, and we'll get into some of that in a few slides. So again, these synergistic effects aren't just the euphoric effects. The synergistic effects are also going to lead to additive toxicities. And specifically, when we're talking about opioids, what we're really worried about are respiratory depressant effects. And the respiratory depressant effects that you see with these various agents are enhanced when combined with other CNS depressants. So if you combine opioids with alcohol, ethanol, you're going to see increased risk of respiratory depression. If you combine opioids with benzodiazepines, increased risk of respiratory depression. Opioids with muscle relaxants, increased risk of respiratory depression. And then you start pulling things from all of these categories, and that risk just goes up. As you can see from, again, some of the evidence that's out there, fortunately, these combinations aren't super common. A study that was done or published in 2020 and done in the, I think it was 2010 to 2013, showed that about 12% of patients had a prescription for an opioid, about 4% of patients had a prescription for a benzodiazepine. And then, as you can see, the number of patients who had the double threat, which they called it in this paper, which would be the opioid and benzodiazepine combination, was less than 2%. And less than 1% of patients had that trinity, or that triple threat. But the reason why it's so important to avoid this combination of agents is, even though the prevalence of prescribing those combinations was very small, the incidence, or the odds ratios associated with hospitalization in the year of that prescription being written, as you can see, dramatically increased with co-prescribing. So patients who were just given a prescription for opioids had an odds ratio pretty close to 1 of having a hospitalization in that following year. Take that in contrast with about an odds ratio of 6 for patients who were getting opioid and benzodiazepine combination therapy. And for those who had a skeletal muscle relaxant thrown on board, you're over 8%. Your odds ratio is over 8 in terms of having a hospitalization in that following year. So as you can see, that combination, while fortunately uncommon, when it does happen, the risks are much, much, much higher for those patients. As you can see from the CDC data, there is a steady increase in the number of patients who experience a fatal overdose involving an opioid and a benzodiazepine. The most recent data that I was able to access is a bit outdated, so hopefully that has started to downtrend at this point in time. But in 2020, that trend was pretty clearly on the upswing. So again, that combination, not only does it lead to an increased risk of hospitalization, it also is potentially associated with an increased risk of fatal overdose. The dangers of this combination are pretty well understood and have led to guidance statements from various government entities, including the FDA and the Centers for Medicare and Medicaid Services. So the FDA basically came out with a statement a few years back warning about the serious risks of death when combining opioids with benzodiazepines, essentially leading to a black box warning against that combination. The Centers for Medicare and Medicaid Services, or CMS, also provided some guidance on this, and they basically said that to reduce the risk of opioid overdose deaths, avoid co-prescribing benzodiazepines. They do offer some guidance, and it's largely the same, right? So avoid the combination when you can. And if you need to combine them for some reason and you can't find an alternative, limit the dose and duration to the absolute lowest dose for the shortest duration possible. You also want to, if you have a patient where combining these medications makes sense, or if you have a patient who comes to you and they've been on these medications long term, don't just abruptly discontinue them. And we'll talk more about this a little bit later, but longstanding opioids and benzodiazepines do require a fairly slow and steady tapering schedule in order to prevent, in the case of opioids, wildly uncomfortable withdrawal symptoms, and in the case of benzodiazepines, potentially life-threatening withdrawal symptoms, very similar to what you would see with like alcohol withdrawal, and people who have been using benzodiazepines chronically for a long time. Again, because of the concerns with that combination, you definitely want to avoid long-term co-prescribing. And if you are going to do it, there needs to be a very, very good reason to do it. It should be a rare thing that occurs, and there should be, pretty darn good reasons for it. And then obviously, if patients are being prescribed that combination, make sure that they have something like naloxone available. The guidance from CMS and the FDA are largely similar to the guidance that we get from the CDC. Again, urging caution when prescribing an opioid pain medication with a benzodiazepine, and then really making sure that the benefits outweigh the risk. Because the risks of that combination are so high, the benefits would have to be really substantial for that individual patient case. Again, there are maybe a handful of times where this is appropriate, but it should really be the exception rather than the norm. And it should be sort of an option of last resort. So how do we prevent this from occurring? The CDC provides some guidance that may help to, again, guide clinicians in order to ensure that this combination is used only when absolutely necessary. So again, anytime opioids and benzodiazepines are being prescribed to the same patient, that should really be a very conscious decision where the pros and cons have been carefully weighed against each other. It shouldn't happen accidentally. And one way that we can ensure that we're aware of all of the different medications that this patient may have access to in their home, it's essential to check the prescription drug monitoring program in your state to see if the patient has other prescriptions. So if you're writing a new prescription for a benzodiazepine, check to see if they have opioids at home or if they've had an opioid prescription filled in the last 30 to 60 days. And vice versa, right? And the PDMP really allows us to get a good view into what controlled substance prescriptions those patients may have access to. Again, if you have a patient who comes and they're on this combination, definitely weigh the risks and benefits of continuing therapy with both of these. And that weighing the risks and benefits hopefully will lead to a conversation that leads to some shared decision making about about the risks of continuing those long-term benzodiazepines, particularly. Obviously, if you have a patient who's using has unpredictable use patterns, they either require large as needed doses for breakthrough pain or anxiety or something like that, if they're requiring very high doses, or if they're using substances such as alcohol, again, skeletal muscle relaxants, things like that, all potentially increase the risk of experiencing respiratory depression secondary to that combination of agents. And again, according to the CDC, there may be situations where this is the right answer, right? But again, it should be a very conscious decision that's weighed carefully through shared decision making with the prescriber and the patient. Again, benzodiazepine withdrawal is one of a very small handful of withdrawals that can actually be fatal. And so benzodiazepine discontinuation needs to be done very carefully under the guidance, preferably of an experienced clinician who has successfully tapered people off of benzodiazepines in the past. If you just cut somebody off of benzodiazepines, they can go into acute benzodiazepine withdrawal, which can manifest in seizures and ultimately lead to brain damage, death, lots of potentially bad outcomes with abrupt benzodiazepine withdrawal. So again, I'm not saying that if you have this combination, you have to stop everything immediately, but it should definitely be a conversation towards eventually tapering off. Another really important piece of the puzzle here is clinician communication. So if I have a patient who comes into my emergency department and they've overdosed on benzodiazepines and opioids, I shouldn't just tell the patient like, hey, don't do that anymore, right? Ideally, there should be some communication with the prescribing providers in order to discuss where we're at and where we may want to get to in order to reduce that patient's risk of having another overdose event. Similarly, if a patient presents and they're taking long-term chronic pain medications, they present to the emergency department requesting refills on benzodiazepines or requesting benzodiazepines for another thing. Again, that should be a conversation between the clinicians in order to ensure that everybody's on the same page, what the risks and benefits are of continuing both of these therapies. And really that coordination of care helps to make sure that everybody's on the same page and doing the right thing for the patient. As I previously mentioned, if somebody does have this combination, it's one of the CDC's criteria for sending a patient home with outpatient naloxone therapy. Personally believe that most people should have naloxone at home, but this is certainly in a situation where they definitely should have this. Just having naloxone in the home isn't enough, all right? If somebody has an overdose by themselves, and chances are they're not going to realize that they're having that overdose and they're not going to be able to administer the naloxone because they're in the middle of having an overdose. And so it's really important for someone else in the home to be able to recognize potential signs and symptoms of an opioid overdose and then know where that naloxone is located and also know how to administer the naloxone to the person experiencing the overdose. Lots of work has been done around educating people on recognizing the signs and symptoms of an opioid overdose, administering naloxone, and helping to get naloxone into the hands of people who need it most. And this is certainly something that we can do through our health systems in order to help reduce the risk, particularly in those patients who have this combination at home. Prevention is the best medicine though, right? So if we can avoid using that combination, that's going to be ideal. Getting into, in-depth discussion about different alternatives for all the different things you can use benzodiazepines for is probably beyond the scope of what we want to accomplish today. But there are are typically alternatives that can be tried before resorting to benzodiazepines for most indications. Benzodiazepines are commonly used for uh, psychiatric conditions, including things like anxiety disorders and sleep disorders. But they shouldn't be the first thing that we try, right? So if patients present with generalized anxiety disorder, cognitive behavioral therapy has shown to be very effective at helping to develop coping strategies, and it may decrease the necessity of prescribing those benzodiazepines. Other non-pharmacologic measures include things like progressive relaxation and sleep hygiene. There are other pharmacologic measures that can be helpful as well. Again, depending on the indication, there are medications like SSRIs and TCAs that can help to reduce the incidence of things like panic attacks and so on and so forth. And then there are other medications that can cause some sedation that may be a little less risky, including things like hydroxyzine. Although anything that causes sedation and has the potential to enhance the respiratory depression that you see with opioids. So even that should be used with caution, but it's probably not as bad as a benzo. Again, alternative strategies for pain management, non-opioid strategies for pain management could and should absolutely be a talk in and of itself. But again, depending on the type of pain that the patient's experiencing, you absolutely want to try non-opioid options first. So things like NSAIDs or acetaminophen. If the patient's experiencing neuropathic pain, things like gabapentinoids, gabapentin, pregabalin, SNRIs like duloxetine, those are going to be far more effective than opioids anyway, and will carry much less risk of opioid-related adverse effects. Again, psychotherapy can be really helpful, particularly for patients experiencing chronic pain. Other things such as trigger point injections and TENS units can be helpful. Again, it really just depends on the situation and the indication for opioids. But obviously, again, good opioid stewardship means trying all these alternative therapies before jumping to opioids. And then even if a patient does require some degree of opioid therapy, continuing to do these different things in order to hopefully reduce the amount of opioids that they're requiring, with the goal of eventually reducing the amount of opioid that they require. So in summary, there's different things that can be done at different levels. So there are system level interventions that can be integrated into things like the electronic medical record and so on and so forth, including integrating the prescription drug monitoring program in order to prompt prescribers to check the PDMP before sending patients home with a new prescription for opioids or benzodiazepines. And if they are about to send somebody home with a prescription for an opioid or a benzodiazepine, and they've got an existing prescription for either another opioid or benzo or some combination of those two, providing an alert or even a hard stop that requires the clinician to stop and think about what they're doing, potentially entering some justification for this combination before proceeding. Again, to ensure that the decision to use those together is very intentional. There's a lot of literature out there about developing opioid stewardship committees and opioid stewardship programs within your health system that can help to develop policies and procedures around opioid prescribing that can help to decrease some of these issues. Another aspect of good stewardship committee is having a robust peer review process so that when there are prescribing patterns that are outside the norm, you have a panel of the prescriber's peers that can evaluate what they're doing and say whether or not it seems reasonable, and that can help to sort of rein in excessive prescribing habits. Another tool for ensuring that prescribers within your institution are following best practices is to provide regular education about some of the best practices for safely using opioids and sedatives for managing a bunch of different types of conditions. And then trying to figure out ways and strategies that you can enhance cross-provider communication within your system and outside of your system in order to ensure that everybody's communicating so that everybody's on the same page. For those of you who are in a prescriber role, or if you work closely with providers or prescribers, try to avoid that combination of opioids and other CNS depressants, particularly benzodiazepines. Again, there's usually some alternative that can be attempted. And if you do need to do that combo for whatever reason, definitely use the lowest effective dose for the shortest duration. Where we really run into trouble with this is when patients have been on long-term therapy with both opioids and benzodiazepines. That creates a really dangerous situation, and it's very difficult to get patients off. But even lowest effective doses with shortest duration still carry a pretty high degree of risk. So again, avoid that combination if possible. If you do have those patients who are on both and have been on both for a long time, don't just abruptly discontinue the opioids, don't just abruptly discontinue the benzodiazepines, but start that conversation, hopefully leading to some shared decision-making about discontinuing or gradually tapering one or both of those agents, or at least getting them down to lower doses. And then definitely make sure that people who have this combination of opioids and benzodiazepines, or if there's opioid use with other CNS depressants like alcohol or skeletal muscle relaxants, make sure that that patient has some naloxone in the home, and make sure that they have somebody there who can recognize an overdose and administer naloxone if needed. With that, I'm going to wrap it up and turn it over for some group discussion.
Feel free to unmute your lines and ask Dr. Christopher Edwards, any questions you might have.
Dr. Edwards, would you like to move to the next slide for the questions? Yes, thank you. Yeah. Okay, well, maybe our audience will have questions as we start our group discussion. So we have some questions here that we would like to discuss, and just to share our experiences in the work that we do and from our own perspective, maybe from our public health perspective, clinical management, community members, community champions. And we would like to share this responses with in our report so we can improve our efforts for the next projects. The first question that we have is discuss the importance of education regarding risk and benefits of benzodiazepines and opioids in your community. What does the audience think? Or maybe something that has happened in your experience in your community or your hospital.
Well, I think it saves lives.
I think it's really important, to have the education on the risks and benefits, because it can, help inform decisions based on their own health and their own treatment options that they need.
Yes. Yeah, thank you. Would you like to share your thoughts or insights?
Someone was trying to
Maybe.
talk who was on the phone. I don't know if you unmuted to ask a question or share your thoughts.
Oh, yeah. So in regards to just the importance of education on this, certainly from a pharmacist perspective, I think education on this is crucial, because there's definitely this risk benefit, excuse me, there's definitely this risk benefit balance. So we know that, yeah, both benzos and opiates have legitimate therapeutic uses. And whether that's benzos for anxiety, seizures, withdrawal, or opiates for pain, they both really carry these risks for tolerance, withdrawal, dependence, and I think those are the main things I think of when I think about why is education crucial.
Yes. Thank you. And what is your name on the phone?
I'm sorry about that. I might have cut out. My name is Madison.
Yes, thank you, Madison. Thank you for everybody's responses. I agree as well. As a public health advocate, I truly believe that education for patients, for their families, community members is crucial. It may be the first step for prevention. And this is not just for benzodiazepines or opioids, but I believe that it's just related to health promotion or all kinds of diseases and prevention as well. We have another question as well. And maybe Dr. Edwards, maybe you can help us with this one. How can healthcare providers and community leaders, champions effectively address benzodiazepines, opioids dependence in your community?
That's such a great question. So I think it comes back to number one, honestly. I think that a lot of this begins with education and making sure that community members understand the risks and benefits of the decisions that they're making or the situations that they're in. Without that education, the education leads to the next steps, which are ensuring that patients have access to appropriate treatments and that they have providers that are willing to, work collaboratively with patients in order to help treat benzodiazepine or opioid dependence in a way that ensures that the patient has autonomy in their decision making, but is also on the right track towards getting to a point where they're no longer dependent on these substances.
Yes, thank you. Someone else in the audience, do we have nurses or medical directors? We have a question in the chat. Does anyone have a case study that may have been difficult related to benzodiazepines or opioids dependence that would like to share?
Rocio, I do.
Okay, go ahead, Jill.
So a friend of mine, an elderly friend of mine, is going through some chemo treatment right now. And apparently she has she's got some broken bones in her back from falling, or I don't know if it was from the chemo. And she was in a tremendous amount of pain. And she doubled up on her pain medication and could not, not by her healthcare provider's advice. She just did this, and she could not get out of pain, and was screaming, that she needed more pain medication, and couldn't get it from any of her providers. And this may be a little bit off course, but I'm just curious. I mean, I'm sure this happens more often than not. And she ended up calling 911 and going to the hospital, and they actually did a procedure in her back to help the compression fractures that she had. But it took her calling 911 for anybody to listen to her, that she was in this much pain. I don't know if it's our healthcare system or whatever, but she's on the road to doing better, but she would have taken anything to get out of pain. That's my case study, I think.
Yeah, Thank you, Jill, for sharing a personal experience with your friends. We have a comment in the chat that sometimes insurance companies will not approve a study such as MRI unless it comes from an ortho or a specialist. So that could have been to hold up from her PCP. Jill, I think it is related to your experience.
Yes, and the red tape, I'm sure. I'm sure it was.
Yes. We still have time. We have another question. And of course, you can share in the chat or verbally. Is there a current withdrawal practice of benzodiazepines and opioids safe in your community? What do you think? Have you experienced anything related to the withdrawal practice? No? Or maybe Dr. Edwards, what are your recommendations for a withdrawal practice, a safe withdrawal practice of benzodiazepines?
Yeah, so I had the advantage of seeing these questions before everyone else or before most of the other people on this call, all the attendees. And so I had a chance to look into like what are the current recommendations for benzodiazepine withdrawal practices. And I found some guidelines. They're 200 pages long. So it's complicated and it's difficult and it requires, again, getting somebody off of benzodiazepines safely requires a long-term commitment to a fairly conservative and slow-going taper. Very similar, honestly, to opioids, but again, I've treated a lot of people with opioid withdrawal, and I've treated a handful of people with benzodiazepine withdrawal, and the benzodiazepine withdrawal scares me. Opioid withdrawal looks terrible. It looks really uncomfortable, and I feel really bad for people when they're experiencing that, but I know they're not going to die. I've had a couple of patients who are withdrawing from benzos where they might have, had we not, gotten them in the emergency department a little sooner. So again, I think as you start to have this conversation about getting somebody off of long-term benzodiazepines or long-term opioids, there are guidance statements available for both. CDC has some guidance on tapering off of opioids, and then I think it was SAMHSA has information about tapering off of benzodiazepines. But again, it should be done very cautiously and at a pretty slow pace.
Yes, thank you, Dr. Edwards. We have some comments in the chat related to that as well. I think Jessica mentions that having lack of pain management providers in Northern Arizona specifically is an issue. Also, Dale, also as a PCP, we have two weight risk versus benefits. Would you like to share something related to your comment, Dr. Dale?
Well, first of all, I don't want to misrepresent myself. I'm a nurse practitioner.
Oh, my apologies. Yeah.
No need to apologize. I just believe in informing people of that. It's very difficult at times for two reasons. Up here in Northern Arizona, pain management is definitely a difficult thing to get our patients into. So a lot of times we have to, or worst case scenario, they get kicked off of pain management. So now they end up having, now they have no way to get their prescriptions. So trying to manage somebody's pain who's no longer in pain management, I have my own thresholds. I follow the CDC guidelines of definitely staying under the 50 morphine milligram equivalents per day. But sometimes you have to supplement. I'm really using a lot of duloxetine. But like you said, your hands are tied mostly due to insurance. And I feel for the lady with that elderly person. I do not know how I would have handled that. I get x-rays and trying to find ortho, and MRIs can be a pain. It can be up to up to a month before getting somebody to MRI here.
Yes, thank you for your insights, Dr. Dale. And our audience agrees with your comments as well related to pain management. Bridget shares with us that pain management is a really important issue. And fortunately, we're seeing greater emphasis on training the workforce. The U of A has a fellowship related to this problem. And with OD2A, with our program, we also have some resources, and we are working on training development for workforce and health professionals related to pain management. Bridget comments that great point about payers being involved, and I think we all agree with the red type. One of our team members, Medicine, who is on the line too, is developing a research related to polysubstance that the aging population faces. We will share this resource with everyone once it is ready to go. But our aging population and other populations are experiencing greatly pain management and the issue of polysubstance as well. So we will continue with our discussion. We still have some time because we are in public health and we like to integrate a comprehensive and holistic approach into all approaches and alternatives. We would like to know from the audience, what are the attitudes and beliefs of benzodiazepines, opioid use and misuse in your community? What do your patients believe or share with you about the attitudes, or what you see in your practice or in your community about the use of benzodiazepines and opioids? Anyone in the chat or in, yeah, Dr. Dale?
In my community, we have we have a mixed bag of people, a lot of addiction issues, a lot of fentanyl. We also have, and I see a lot of elderly patients where if you try to mention, giving them even a short-term opioid prescription, you get a lot of pushback, but they're unable to perform their ADLs. And you're trying to explain to them, I just want to turn the noise down. So there is a definite lack of understanding. I like the alternative approaches. I use a lot of antidepressants. Duloxetine has changed people's lives for the better in many ways, and also amitriptyline in low doses. But I do steer away significantly from benzodiazepines. I could probably, on one hand, to count how number of benzos I've prescribed in the past 6 months. I lean more towards some low strength muscle relaxers, and my go-to is typically a short-term course of hydrocodone. I have only a few people on oxy. Just the idea of Loratabcan is more prone for addiction, but oxy is more prone for overdose. But again, I have some pain management patients that it's difficult trying to navigate this. I don't know what the answer is.
Thank you, Dr. Dale. And we have some movement in the chat as well that agree with your point. Bridget, you point about the difference between well-researched area versus under-researched area, that it's important and makes coordinating care and using technology is a must. Yes. We all agree with Bridget's comment, and that goes back to one of the questions that we have in the slide, which is related to the strengths and barriers that can contribute to safer and more responsible prescribing practices in your community, in our communities. So what are the strengths and barriers that you see in your communities? And Bridget already mentioned maybe technology and coordinating care. What else? What are the strengths and the barriers? We have some attendees from the state, from Arizona, but also from out of state, from Oregon and Ohio. So maybe we can share what is happening in Arizona, what's happening in Oregon in terms of strengths and barriers.
You okay if I share?
Yes, please.
Yeah, I'm in Nevada, so upper Nevada. And yeah, there is quite a few barriers being part of the IHS facilities. You know, there are limitations on who we can treat or how we actually perform the treatment. So it can make it very difficult because generally pain agreement, just like they were talking about, they can be overseen. You try to communicate it, educate the patient that they need to stick with it, whatnot. And they tend to fall off base because they're like, well, it's coming consistently. I've been compliant with it. I don't need to do it anymore. You should give me my medication. So it's quite a bit of barriers, and also working with tribal facilities as well. It can be kind of a hurdle to jump. So I know that. So we got the federal, and then we have the state, as well as we have the tribal governments that can really make it difficult to kind of tackle some of these chronic conditions with like opioid addiction as well as benzo addiction and whatnot.
Yes, yeah. Thank you very much for sharing your experience from Nevada. We have some comments in the chat as well that mention about the largest barrier, which is the lack of pain management providers, and also insurance coverage for pain management. There is still a stigma about addiction and pain management. Yeah, so we believe that these barriers and strengths can be shared across the state, across the nation. Even though communities are so unique and have their own characteristics, we all agree that at some point we share some of the same barriers. We have just one more question before we end. And our colleague Brianna is already posting the survey link in the chat. We will appreciate everyone to share your feedback with us so we can improve our efforts to better support our rural communities. And we are leaving the biggest maybe question for everyone, which is related to what is missing? What are we missing? What are we not doing related to benzodiazepines and opioids use and prescribing practices that we can improve, that we can work together as a state and as a nation? We can leave the red tape aside because we know that dealing with insurance, dealing with some federal, maybe some state, some tribal specifics, we may not be able to address those right away, but everything else, what are we missing? What can we do together? Anyone in the chat or still sharing verbally?
I did have something to share just regarding the last question.
Yes, please go ahead.
I was just going to say that I definitely think that in Arizona today, one of our key strengths is having safeguards like the PDMP, which allows providers, pharmacists to at least be able to spot high-risk prescribing patterns. And we also have pharmacists that are accessible to educate and counsel, follow up with patients. I think it's also a strength that we have this growing emphasis on co-prescribing with naloxone and trying to integrate harm reduction messaging into clinical care more than before. But yeah, I'd say definitely just a little bit of a brief personal story. But my father, he has chronic pain. I remember when he was getting and recovering from his back surgery, he definitely had a little bit of stigma, or he was kind of scared about how he was going to be treated in regards to discussing his pain and talking about it. And he was later hospitalized, and he told me he left feeling really ashamed, and not because he'd misused anything, but just of how his request was received. by providers. And I really think that that stigma can create a barrier to really what we want. And we want is more open communication. But yeah, I think stigma can play a huge role in just making patients, even people we know, our family, just more hesitant to engage in discussions like this about pain management.
Yes, thank you so much, Madison, for your insight. I think the audience shares some of the same thoughts. Jessica is commenting that providing education about proper expectations regarding pain and maybe not being entirely pain-free may prevent addiction or drug-seeking behavior. And the community shares the same thought. So thank you everyone for sharing. Yes, so what else are we missing? What can we do together? And I think everyone agrees on education. Education about prescribing practices, about stigma, about pain management, etc. So engaging in these discussions, like you mentioned, Madison, is so crucial because we are opening the floor for more opportunities, and also maybe just start thinking about the gaps, about the strengths, about what can we use that it's working in some other states, maybe in Nevada, maybe in Oregon, that we can use in Arizona. So we appreciate everyone's feedback and sharing your thoughts and your experiences with us. And the community in the chat mentions that Bridget, yes, understanding that people are seeking relief and understanding what the pain is and its root cause. So before we leave today, we encourage everyone again to please take a look at the survey in our next slide. If you can move to the next slide, Dr. Edwards. We have the QR code. We have some resources that you can use and that you can share with your team and your communities. These resources are statewide, nationwide, and also that our program has developed. The 3 slides related to this and also pain management according to the CDC prescribing guideline. And here we have a QR code and the link for the evaluation survey. Please take a minute or two to complete the survey. We would like to hear from you. Your feedback is so important for us. So we can improve our efforts to address the opioid crisis in rural communities. And our colleague Stefania shared in the chat some resources that we put together related to this topic, and we will send a follow-up email with more resources and also with the evaluation survey. The recording of this presentation, like Jill mentioned, will be sent to you in a couple of days as well. So please expect that email and share the resources with your team and your community. Does anyone have a question or concern or a thought that would like to share before we close?
Just one final thought, kind of getting to your question about what we can do today. And I think the big thing, I really like that people are focused on education, communication, and I think using the tools that we have is so important, right? So, we all have access to a prescription drug monitoring program. Use it, right? We all have the ability to prescribe naloxone in people that we think are higher risk. Use it. Think about it when you're doing, co-prescribing benzodiazepines and opioids. Really make sure that this is the right thing to do for that patient. So like, really implementing those best practices that have already been described has helped and will continue to help. And then you can also lead by example, right? So if your peers see you doing those types of things, that helps to reduce some of the stigma associated with it. You're having these conversations with your patients, it helps to reduce some of the stigma associated with pain management. And so again, just, there's a lot that there's a lot of progress that has been made in the last, few years. There's a lot of work to still be done. But I think the low-hanging fruit is just making sure that we're doing those best practices that have been described. And it sounds like you guys are all doing that, which is awesome. So thank you again.
Yes, thank you so much, Dr. Edwards, for your comment. I think Madison on the phone mentioned that too, that using our current resources, like the monitoring and surveillance database that we have, that it's available for everyone. This information is in the list of resources that Estefania shared in the chat. So please download this resource list and share with everyone. Thank you, Dr. Edwards, for your expertise, for sharing your experience, your knowledge with us. I'm sure that everyone has learned something new today. And thank you everyone for attending this webinar. We look forward to next webinars with our programs here at the Center for Rural Health and the collaboration with different states that support the critical access hospitals. Expect an email from us in a couple of days with more resources. And if we don't have any questions or concerns for Dr. Edwards or for everyone, we end this webinar.
All right. Thank you, guys. It was a wonderful session.
Thank you. This was awesome.
Thank you, everyone.
Yes, thank you all.
Thank
I
you,
appreciate
everyone.
the information. It was really nice and helpful.
Thank you, Brian, and everyone who participated in the chat, and Beverly as well.